Hi, everybody. Welcome to tonight's Woo You event. I'm just going to give everybody a moment to make their way in. How are you, Dr. Janelle?
I am doing great. How about you?
I'm glad to see you. We don't see as each other as much in person. You're everywhere. I'm nowhere. So
No, I see you. I see
I'm
you
here.
online. I read all
So
your articles and things. So I was
thank
so
you.
excited to see you moderating today.
I am really excited. It looks like we have a ton of people that just made their way in. So without further ado, I am going to kick off. So welcome to tonight's Woo University event, LID, Listen, Identify, and Diagnose with Dr. Janelle Davison. I'm your host, Dr. Jennifer Stewart. And thank you to Tarsus for providing a medical education grant to support this event. Just some reminders, for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and make sure to ask questions using the Zoom on-screen floating panels. And there's where you can find them if you're on a mobile device. So it's my great pleasure to welcome Dr. Janelle Davison. She's an award-winning optometrist with 19 years of clinical experience. She's the owner and CEO of Brilliant Eyes Vision Center and the owner and clinical director of Visionary Dry Eye Institute Referral and Co-Management Center in Georgia. She's also the Chief Visionary Officer at Paradigm Software, a web-based retail optical solution, and the co-founder of SCORE Inc., a nonprofit organization that works to introduce young women to the field of optometry. She's a member of the AOA Aesthetic Task Force and a consultant for Tarsus, Alcon, Erasis, Sight Sciences, and how do I say that, Janelle?
Beatrice.
Beatrice, thank you. When she's not saving sight, she enjoys spending time with her husband of 18 years and her 2 children. This is Dr. Davison's first time presenting here at Wu University, so a huge welcome to you, and I'm going to turn it over to you.
Thank you. I'm so excited to be here. I'm going to go ahead and share my screen. All righty. So sharing the screen is half the battle. You would think 5 years post-COVID and doing everything virtual that will go over without a problem, but sometimes you never know what happens. But I'm so excited to be here this evening to talk to you about Demodex blepharitis. This has become one of my favorite topics. Demodex blepharitis is not new, but now we have a novel treatment to really add to our toolbox to manage ocular surface disease. As Dr. Jen Stewart mentioned, I do a lot of ocular surface disease. I have a primary care practice, but within that practice, about 8, 9 years ago, I started really to get into ocular surface disease, dry eye, MGD, blepharitis, and really grew that practice. Last year, I was bold enough to separate as a separate specialty my ocular surface disease, dry eye, MGD, Demodex blepharitis, all of that into its own dedicated space within a medical complex. And so I get to spend a lot of time managing patients, specifically with Demodex blepharitis. So we're going to get in it today. I'm so excited. We're going to talk about listen, identify, and diagnose. And so these are some of my disclosures. Those were presented a little bit earlier. She did introduce me, but this is one of my favorite pictures. I always like to keep my lectures a little bit light and fun. So this is my family. It's the first time I took my kids to the Caribbean, and we went on a glass bottom boat cruise and snorkeled. We had a super duper time over one of the spring breaks. That picture is just so picturesque, and I'm ready for another spring break trip. And so we're going to talk about our learning objectives. I'm going to take at a different angle. I really like the topic, listen, identify, and diagnose. I think a lot of times we get so excited about diagnosing the patient, managing the patient, but we forget about that listening component, especially when you're managing ocular surface disease. You have to really get in tune to listening to your patients to really figure out what is the root cause of the issue so that you can devise a customized treatment plan for your patient and help them really reach their clinical outcomes. And so we're going to learn how to be active listeners. We're going to understand the disease state. as well as gain insights into recently approved clinical data for lotilaner, the novel treatment for Demodex blepharitis. We're going to explore the prevalence of Demodex blepharitis and discuss how to seamlessly integrate ocular surface disease, Demodex, with some aesthetics treatments and things that you may offer in your practice and dry eye. So listening is super important. Listening helps us to really understand why the patients are coming in to see us. We're going to go through some pictures and things, and we'll see some clinical cases of some obvious Demodex cases. But sometimes you'll get those cases where it's not as obvious. You look under the microscope and you don't see obviously under the microscope that this patient may be suffering from Demodex blepharitis. And you really have to learn how to listen. For instance, yesterday I was in my dry eye clinic. I split my time. And so a couple of days out of the week, I go to the dedicated space. I had a patient come in. She was under a slit lamp, and her main complaint was fluctuation in her vision, some mild itching, and grittiness. And so, of course, you're thinking dry eye, MGD, you're kind of running through all these differentials in your head. We did all her anterior segment imaging, testing that we do on our ocular scarograph 5. We have our dry eye protocol in there. And we were going through her case, and I had one thing in mind, but I got a little closer look at her lid margin. And there was no obvious signs of Demodex blepharitis on the lid margin. And so I had to turn and start to ask some specific questions to see if I can elicit that this patient may actually be suffering from DB. And that was one of our diagnoses. So learning how to really listen to your patient so that for you can really reach those clinical goals, because you may not listen and you may see some disease states, but if you listen to the patient, sometimes they'll tell you what their ultimate goals are. And so if their main complaint is itch, and you are really good about getting rid of the redness in their eye, but their eyes are still itching, then you have to help that patient reach their clinical outcomes. And so especially managing Demodex blepharitis, dry eye, allergy, MGD, a lot of them have very similar symptoms that the patient may complain about. So you have to really have a keen ear and have a process set in place to make sure the patient doesn't kind of get lost, that their complaints don't kind of get into a big bundle of a hodgepodge mess of complaints and trying to figure out which is which. And so red eyes, itchy eyes, watery eyes. And one key thing that I like to look for is crusty eyelids, specifically in the morning. We learn a little bit more about Demodex blepharitis is that they're produce these crusty, waxy, cylindrical collarettes on the lid margin, and they're more pronounced in the morning. They come out at night because they really like melatonin. So you really have to listen to the patient because a lot of these symptoms are very similar to other things that the patient may be diagnosed with. And so that brings us to empathy-based care. I was in a lecture about a year and a half ago, and one of the doctors was talking about dry eye disease in conjunction with traumatic brain injury. And one thing she talked about was empathy-based care. And empathy-based care means that you actually put yourself in the shoes of the patient. And so it's one thing to be sympathetic, right? I'm okay if you have sympathy for me, but I prefer if you have empathy. Empathy means that you can put yourself in my shoes to kind of better understand what I am going through. And there's research that has shown that doctors who are really good about practicing empathy-based care have better patient clinical outcomes because that provider is able to put themselves into that patient's place to understand where they're really coming from as far as these symptoms and really see how these symptoms, specifically DB, can be impactful into their daily life activities, how they are certain things that they're not doing. We'll learn that some of these things with the symptoms that they have with Demodex blepharitis affect how they interact with their families, their work, their overall confidence in themselves. And so to be able to better understand and manage those patients, you do have to practice empathy. A lot of people, a lot of my peers, you say, oh, I don't like ocular surface disease, dry eye, DB. Those patients require a lot. They take up a lot of chair time. But if you really get in tune and practice from that empathy standpoint, you'll understand how a lot of these symptoms can be very debilitating and really affect the patient's overall daily life function. There's been research that has shown once the doctor is able to practice that empathy-based care, the patient trusts you, right? And so when the patients trust you more, they're more likely to follow those customized treatment plans, which in turn is going to allow the patients to reach those clinical outcomes that they're looking for in you as well. And so some tips to become a active listener. Concentrate on the sender, the person that's actually talking to you, so the patient. With the world of EMRs and computers, sometimes it's easy to just come right into the exam room, sit down at the computer, or even if you have your iPad or laptop in your hand, to just look at the chart the whole time and you're scrolling through. And sometimes I have to catch myself to make sure that if I am looking, because I want to look at the chart to see if especially if it's a previous patient, that I do take time to look up, or sometimes I put it to the side and actually so that I can pay attention to the patient better. Ways to be able to concentrate on the sender and not so much with the EHR is to have a scribe. I've implemented an AI assisted scribe. So it's running in the background on my computer. So therefore, I really let the scribe listen to everything that we're talking about so that I can really actively listen to the patient. That's something that I implemented into my ocular surface disease practice. And it's really been a game changer for me with my note taking, as well as my ability to really listen to the patient. So listen for the intended message. So you have to listen to the patient and listen with, not with bias, right? Sometimes we go in and we may see before we look in some of the chief complaint. And so we go in, our tech wrote down a chief complaint. So we may already walk in thinking we have an idea of what this patient may be complaining about, what their issue may be. And so you really want to be able to go in and listen for the intended message. Refrain from premature judgment, right? And so sometimes us providers, our job is to be of service and help our patients, but sometimes we have long days, sometimes we're very tired, and so sometimes we go in and we're thinking one thing and we just want to jump to a conclusion, say this is what we're doing, I'm going to write this script, this is what it's got to be, without actually listening and not jumping to a premature judgment. Reflect and paraphrase, meaning let me make sure I understand what you're saying. Repeat to the patient what they've said to you to make sure you understand what they're complaining about or what their active goals are. I say that a lot when I'm working with, especially my ocular surface disease patients, because I get patients a lot of times that have driven hours to see me. I may be their 6th or 7th doctor that they've seen. And so I want to make sure I really understand what the issue is and where the gap has been and why they aren't reaching their goals. So reflect and paraphrase. Ask for clarification. It's okay to say, I don't quite understand. Can you repeat that again? Or let me say back to you what I think you're asking me, and you let me know if that's correct. Maintain focus. Make sure you're looking at the patient, providing eye contact. In some cultures, eye contact is a big deal. If you're not looking at the patient and they feel like you're not listening, even though a lot of us we can multitask and find things that may not be looking at you, but completely hear and understand everything. Your person up the chair from me feels like I'm not listening to them, that there's no way I can understand what they're saying because I'm not. Avoid distractions. So make sure you minimize distractions in the exam room. I'm getting a little note here saying that my internet is unstable, so hopefully I'm not freezing at all. Make sure there's no, I'm just gonna check to make sure that I'm not frozen. Okay, good. Good. So I'm not frozen. I'm still alive. And so avoid distractions. So I mentioned earlier how I implemented AI assisted scribes, have a scribe in the room. If you have a scribe in the room, sometimes to me that could be a little bit distracting as well. So make sure you have a system and process in place that the scribe is not taken away from your ability to focus on that patient and listen fully before responding. Some of these things seem very elementary, but you'll be surprised how doctors don't have good chairside manners. And if this was pretty commonplace, empathy-based care, be an active listener, then I don't think most patients will be visiting 6 or 7 doctors to be able to find for relief with ocular surface disease, DB, and dry eye. And then cultural competence holds a pivotal position in healthcare and significantly influences the process of active listening. So if you are practicing in diverse populations where you have patients who speak different languages, practice different religion, various different skin tones, races, ethnicities, then you need to be very versed in those different cultures. So that way, when you're interacting and engaging with these patients, that you don't by default offend someone or have a particular patient feel like that you're not in tune to them, right? And so I want to keep that in mind. I work in a melting pot. I'm in the metro Atlanta area. And so I see patients all races, ethnicities, religion, men, women. So I'm pretty versed in making sure that I'm making each patient feel comfortable and that I'm listening to them. And so let's identify DB. And so I have a lot of cool cases and pictures here that I've actually just taken in exam room. Some of them are with our imaging system, and some of them were just with my iPhone that is right up against the oculars. But we're going to talk about identifying Demodex blepharitis. We want to keep this really simple. There are about 25 million people that we estimate in the US that have Demodex blepharitis. And just to kind of put that in context, we'll do about 4 million cataract surgeries a year. There's about 3 million or so people in the US that have glaucoma. And so there's a huge opportunity for us to improve the lives of our patients and make an impact if we can properly identify Demodex blepharitis. And so what is Demodex? And so I hope you guys are not eating dinner. I had dinner around 7 here on the East Coast, but Demodex is a microscopic mite. It feeds on the oils that are produced by the skin and the eyelashes. It is a part of the arachnid family. I tell my patients there are 65 different species of Demodex, and 2 of them are found in the human body. That's going to be Demodex folliculorum and Demodex brevis. The clinical manifestations of Demodex are itching and redness. And we talked about before, it causes a lot of crusting around the eyelids that can lead to further complications if left untreated. And we'll learn further, but the pathognomonic sign for Demodex in diagnosing is collarettes, which are these small, whitish, cylindrical deposits that are found at the base of the lash, really the mite by waste product, mite poop. And I actually say that to my patients, it's mite poop. And so these are the common types of Demodex on the skin. Talk a little bit briefly about Demodex folliculorum. This one's typically found mostly in the hair follicle. And then the Demodex brevis is usually associated most with inflammation, and it's found, we believe, in the sebaceous gland. So remember, Demodex likes hair follicle, sebaceous glands, things where there's oils where they can feast. And we have all of that around our periorbital tissue on our lid and lash margin. And so this is an ideal place for Demodex. And so when you're managing ocular surface disease, keep this top of mind. Don't miss this. I have a lot of patients who self-refer to me who have been taking numerous medications to manage their dry eye, but they're still having episodic itchiness, fluctuation in the vision, redness, and they actually have Demodex that was undiagnosed and not treated. So the mechanism of the disease is there's a mechanical, bacterial, and chemical Demodex. If Demodex blepharitis is left untreated on the lid margin, or DB, which will make it a little bit easier, it can cause changes in how the lashes grow from the lid out towards the away from the lid. And so it causes what we call lash distension. So the lashes, instead of kind of going out that way, they kind of take a 90 or 45 degree angle away from the lid margin. You also notice some lash loss. And so sometimes if you don't see some evidence of collarettes, but you see the change in the position of the lashes, how they're coming out of the lid margin, you might want to think in the back of your head that this person might be having DB. Bacterial. So there's a bacterial component to the Demodex blepharitis. It carries bacteria in their gut. And as they release those products onto the lid margin in the form of those collarettes, it can increase the risk for bacterial infections. There's also been some studies that have shown that within their exoskeleton, so the shell of the Demodex mite, that they had carried bacteria there as well. And then you have a chemical component of it where the mites have been associated with altered meibum. And so we'll get into a little bit more, but there's been some recent research that's come out that's shown that DB is heavily associated with MGD, and we know now that the mites can change the quality of the meibum, which is really important if you're managing other forms of ocular surface disease to repair or improve that tear film. If left untreated, the chemical component can cause inflammation on the front part of the eye, which can cause some degrading the conjunctival tissue. So once again, increased inflammation, bacterial infections, lash loss, changes in how the lashes come out of the lid margin. So this is definitely something that could be impactful to our patients. Prevalence of Demodex in eye care centers. So there was a retrospective study that was done that looked at about 1,032 patients. And from there, it was discovered that about 58% of the patients who walk into our practice have Demodex blepharitis. And I think that number is a little bit low, right? I think that number is conservative, but that's what the data says. There's days where I'm in clinic and it's like, is it DB day? Like everybody I'm looking at has Demodex blepharitis. And so 58% is a pretty large number. So definitely when you're managing your patients, even in your annual routine exams, you may want to incorporate some way that you're making sure that you're not missing these patients. We all have different screening protocols in place, a lot of us, to properly manage and screen patients for dry eye disease so that we can filter them for additional testing. You may want to have some way that you and your staff look for DB and not miss out on this. We'll talk about a little bit way that it's easier for you to diagnose it on the slit lamp, but you may want to have a process in place so that stays top of mind for you. And then also, which is important, if you're here and you're managing ocular surface disease, 59% of the patients that were in this retrospective study had dry eye. So DB and dry eye are hand in hand. I was lecturing about a week ago in Nashville, and I said, DB, dry eye, and MGD, they're brother cousins. And they were like, what? I was like, do you guys know what a brother cousin is? And so I jokingly said a brother cousin is basically a cousin. I had a cousin growing up that it was only three of us. And so two girls and a boy. He always came along to be my brother's playmate. And so eventually we called him my brother cousin because he was always with us, complete that, make us an even number, to the point that my kids actually thought he was their uncle. And I had to say, actually, he's not your uncle, he's your second cousin. And so when you're in practice, DB, 58% of the patients walking through that door are going to have Demodex blepharitis. And right behind that, 59% have dry eye. So you want to definitely keep this top of mind when you're managing both of those. And so when you have providers that say, oh, I don't see a lot of DB, or DB is not that big of a deal. Well, 51% of the patients that were in this same study with DB actually wore contact lenses. 50%, 56% of cataract patients. So if you're referring cataract patients for premium IOLs and you're missing or not managing DB, it's really going to affect their outcome with those premium IOLs. It's 59 or 60% of dry eye, 65% of glaucoma. And so how many of you on here manage glaucoma patients? And so we know how much the drops from glaucoma can potentially affect the ocular surface, but don't forget about the lid and lash margin. I have had several glaucoma patients who've come in and they were in for their regular glaucoma checks, eye pressures and everything were great, but they were complaining about itchiness of the eyelid. Look under the lid margin, check it. I want to say I'm a good provider. I didn't miss it for their last check, but I see DB, prescribe medication to be able to help and improve the comfort of their eyes. And then meibomian gland dysfunction, I kind of highlighted that because there's been some new recent data that's said about 57% of patients with DB will have MGD. So if you're managing meibomian gland dysfunction and DB, we'll talk about how prescribing a particular medication may help with both of those issues for your patients. The impact of DB. So these next slides are the ones I really like. We all know about glaucoma and cataracts and macular degeneration and how blindness can significantly impact someone's vision and impact their daily life activities. But a lot of us don't think about some of the more anterior conditions as being impactful to the patient's daily life. So there was a study done, the Atlas study, that showed about 80% of the patients reported a negative impact on their daily life activities that had DB. 47% report feeling conscious of their eyes all day, difficulty driving at night, 34% difficulty wearing makeup. I'm a makeup girl. It's 8 o'clock in the evening and I'm getting on a virtual call and I put my mascara on, some blush and some lipstick. And so if I had a condition that really affected my ability to wear makeup, that would impact my daily life. And 30% of patients needed additional time for daily hygiene routines. And so patients that have Demodex blepharitis, prior to recently, they had to incorporate additional routines into their day to make sure that they're adding that daily lid hygiene. So this can be very impactful to the lives of your patients. So this is my patient here. And this is my very first patient that I prescribed a medication for, lotilaner, which we'll talk a little bit more about. But she walked into my practice about 3 years ago, 2.5, 3 years ago. And she actually, it's ironic, she came in today for an annual exam. And this was she walked in. Her main complaint was, I just need to get some glasses. And it's been a while since I had an eye exam, but I am experiencing gritty, itchy lids and gritty and red eyes, right? So she just walked in for glasses. And so to my surprise, that's what we saw under the slit lamp. And of course, took an image of this, but there's a lot more going on than just needing glasses. And so the impact of the journey on Demodex blepharitis, the Atlas study showed once again that 51% of patients experienced blepharitis for 4 years or more. And that patient was no different. When we finally did the exam, I got under the slit lamp and I started saying, I think I understand why you're having the itchiness and redness and discomfort. Gave her the diagnosis of DB, and she said, wow, I've been dealing with this for years, and you're not the first eye doctor I went to, and nobody really could tell me what was going on. 33% of patients report visiting 2 or more eye care providers. And I see that regularly. Like I said, I've had patients come to me that drive from, different places and it's just DB, right? And they've been to multiple doctors. I've had pediatric patients where I'm like, hey, how long has this been going on, mom and dad? And they're like, I've been to the pediatrician, I've been to urgent care, I've been to another eye doctor. Nobody seemed to know what it was. And so 33% of patients go to 2 or more doctors before they're diagnosed with DB. So with all these people on here today, your office needs to be the last stop. I want patients going to different doctors for DB management. And 81% of the patients said that they sought some type of treatment, meaning I know something's going on, my eyes are irritated, I'm plucking and lashes, little crushes in my lashes, something's got to be going on. I'm seeking treatment. So you don't ever want a patient coming in seeking treatment and they don't get it. And that goes all the way back to our first slides where are we not listening to our patients? And 80% of the patients report that Demodex blepharitis had an impact on their daily life activities. So diagnose Demodex blepharitis. And so diagnosing needs to be really easy. We don't want to take a lot of time away. I've gotten my spiel down now where it's just like this. We make the diagnosis. I show a few pictures. Sometimes I may take a picture. I'm prescribing, the patient's on their way. And so we don't want this to be a drawn out thing. I am a practitioner. I own my own practice. So I am realistic and sensitive to that. You probably will have to figure out how you will incorporate that into your flow. Will you bring the patient back? Will you initiate treatments at the routine exam? So those are some little nuances that you do have to work out. But for the most part, diagnosing the patient should be fairly easy. And so collarettes are a pathognomonic sign of Demodex blepharitis. And we talked about a little bit earlier that the collarettes are these cylindrical dandruff that are composed of mite, waste, and products and eggs. You do want to differentiate a collarette from just like traditional blepharitis, where it's more like flaking, debris, more like scurf. Those are usually going to be down more towards the interior portion of the lash margin and not as taut and tight against the base. Usually these collarettes here are really attached to that lash margin, and patients really have to work. They're like scratching and scraping to get that stuff off of there. And this is another good picture down here where they're right at the base of the lid margin. And so when we really first started talking about DB and managing DB with Lodolan or Xdemvy, which we're going to talk about, we wanted to kind of get into a position where you wanted to see 10 collarettes or more. But we're learning more and more now that you see one collarette, I always say, well, there's 1, there's 5, there's 10, there's 20. They're there. Then you want to go ahead and make that diagnosis. What I've been learning lately is that a lot of patients have been experiencing these crusties and this cylindrical buildup, these collarettes, that they've just gotten so routine to cleaning this off very well before they come to see you. And so this is a pathognomonic sign, but you do want to think about and listen for those other common symptoms and make sure that this stays top of mind, because it may not just be where they have dry eye. They may have dry eye in conjunction with DB, and you may not see as many collarettes on that lash and lid margin because the patient has cleaned them off. I had a case this week where her lid margin actually looked really good, and I had to dig and dig, and finally I said, well, tell me about your mornings. When you wake up in the morning, do you experience crustiness? Is it to the point where you have to really, and they're like, yes, every morning I've been doing this. I've been doing this for about a year now. And so in defense of some of my colleagues, you may not catch it if you're not listening for the other key signs, because they're really good about cleaning these off, right? There's a lot of talk out in the social media world about mites thanks to lash extensions. So a lot of patients are aware and they're cleaning these things off, and they may be using some of the traditional base cleansers at home. And so this is a pathognomonic sign. You don't need 10 or more. Where there's 1, there's 5, there's 20. But also don't forget to listen. Use those empathy-based skills that we talked about earlier, because you may not see these and patients may clean them off. And then there were studies that have shown that 100% of patients with collarettes had Demodex blepharitis. So if you see a collarette, what you want to take from this slide is that if you see a collarette, then that patient has DB, right? We don't want to wait to see if the collarettes get worse. You may want to ask some questions to just confirm that diagnosis, but you could be confident that this patient has Demodex blepharitis, and you can go ahead and prescribe, and we'll talk a little bit more about what you're going to be prescribing. Way that I go about diagnosing and making sure that I catch this, I've kind of altered my slit lamp routine, is you want to simply have the patient look down. So when you are looking for collarettes, let's say we have that traditional patient that walks into the exam room that has those collarettes that are on the lid margin. Sometimes if those patients are looking in primary gaze, it is very hard for you to see those collarettes. So you want to train yourself, if you're not already doing so, to have the patient look down. And in some cases, you may need to mag up. Typically, I work in 16x, so usually I see everything I need to see pretty well. But if you need to mag up, it's suggested that the patient looks down, you mag up, and then you kind of scan across the lid margin, looking for any evidence of collarettes. And remember, if you see one collarette, then that patient has Demodex blepharitis, because collarettes are the pathognomonic sign. If you don't have that patient look down, there may be a possibility that you may not be able to see the collarettes as well and may not be able to properly diagnose a patient. So the takeaway from this slide is to have the patient look down. And in some cases, if you have an older patient, I'm not older, but 40s is rough. You still got to pull up on my eyelid. So if you have an older patient, you may have to pull up on the eyelid, have the patient look down, pull up, mag up, pull up, and then scan. Those are some things that you do. And then because I'm an ocular surface disease specialist, I always say push to. You want to push on the lower lid, or you can push on the top lid, just so you can see, to check the meibomian glands to see if they're getting any excretion. And then you also want to evaluate what that, any secretion of oils, and you want to evaluate what that secretion looks like. So you want to be able to grade those. So you have the patient look down, mag up, pull up, scan, and then push on that lid margin, so that way you can evaluate those meibomian glands. And so these are my pictures of look down, mag up, and scan. And once again, we want to keep it simple. If you have anterior segment cameras, if you have any imaging system, great. Go ahead and take a picture. A picture is worth 1,000 words. A lot of times the patients need the motivation to go through the current therapy. A lot of times they don't. If you use the word might, most of the time they're ready to get on board and figure out what they need to do to get rid of it. But these are some different pictures of patients that I've taken. And one that is in here that's kind of encased in this black casing, that's just me taking my camera and just putting it up to the slit lamp, to the oculars, and taking a picture. So if you have the resources to spend on an anterior segment camera, great, go for it. You can purchase a system, go for it. But if not, if you keep your iPhone or Android in your pocket, just put it up to the oculars, and this is with no special adapter. And in most cases, you're able to get a good enough picture to at least educate and show the patient. Otherwise, you can have, there's some of the reps can give you, which we'll talk a little bit more too about, some brochures that have pictures of Demodex blepharitis, but it doesn't take a lot. But you do want to practice, are you going to take images? Are you going to bill for those images? Are you going to have the patient come back? In the beginning, I used to take a lot of images. Now it's touch and go. I take some, sometimes I don't, sometimes I do, but I'm just really good about listening, making that diagnosis, and having that conversation with the patient. So these are some of our current therapies that we used before we really had a novel topical therapy. Some of these therapies I still use. I still use these therapies in conjunction. And so we are the in-office blepharitis exfoliation with Blephets, Zest, new lids. We have our hyperchloride spray. We have our tea tree-oil-based cleansers and wipes, light-based therapy, and also put on here, there's some talk about topical ivermectin cream. So these are some current therapies that we've used in the past to manage DB. The only thing about a lot of these therapies is that they're not FDA approved. And I did want to mention, We do know, we talked about earlier, some of the chemical and bacterial association of DB. There's some thought that because DB causes inflammation and changes on the biofilm, that some of that actually moves from the lid and lash margin. It actually goes underneath the fornices of the upper lid and the bottom lid. And so there's a new device that allows you to be able to clean some of that out, get rid of some of that inflammation. And so these are some current therapies that a lot of us use in clinical practice to manage DB. This is some literature that talked about ivermectin cream to manage DB. There's also been some promising literature that talked about light-based therapy with M22 managing DB. But one thing that we do know with a lot of these therapies is that they're not FDA approved. And one big issue with these therapies is that they don't eradicate the mite. They don't eradicate all of the mites, the current mites that we see, as well as the eggs. And so we need to have something that we know that's going to be safe and have good efficacy for us to be able to use with our patients. And so this is back to my case. My patient here, this is my patient. And so ironically, she must have knew I was doing this talk today, that she was in today for an annual exam. But she was one of my first patients that we prescribed this novel treatment for. We have been doing all of those previous therapies. I think everything on that screen we had tried with this patient, and relentlessly DB would come back, and it would come back about every 4 to 6 months. And she was cleaning at home, doing everything that she could. And so the very, very first picture I showed you in the beginning of the lecture is how she walked into my office. We would have her come in and we would do lid cleanings in office. She would clean at home, and she still would come back and still have a pretty significant amount of Demodex or blepharitis, Demodex on the lid margin. Still a significant amount of collarettes. There's still a lot of redness and itching, a lot of telangiectasia. She failed with pretty much every in-office treatment that we had available for her. And we prescribed. She was one of my first patients that I prescribed lotilaner ophthalmic solution to. She took the medication twice a day for 6 weeks. It was so early that I prescribed that it wasn't even in my EHR. She didn't even have an appointment today. When it hit the EHR, I called her and said, hey, why don't you come in? We're going to come on in. I think you're a good candidate for this medication that's out, and I want to prescribe and see what happens, because we have been trying really, really hard to get rid of this. You've been doing awesome with managing your symptoms and doing what I tell you to do at home, but we're just still aren't reaching those outcomes. And so come on in. And so she came in, we evaluated, we wrote the prescription. She did everything that I asked her to do, and she came back in 6 weeks, and this is where her lid margin was, right? So we were able to reduce the number of collarettes on her lid and lash margin. We see we got might be one little flake down there, but we really improved her daily life function. And then from here, then we revisited some of those current therapies that we were doing before. And then also, because you can see, if you look at her lid and lash margin, you see a lot of that telangiectasia there. She was diagnosed with ocular rosacea as well. So this was an awesome springboard for now us to go move on to those other advanced therapies, light-based therapies, to really help reach those long-term clinical goals for her. I don't have updated pictures today, but she came in today for her annual exam. And so she was one of the first people for me to prescribe this. And lotilaner was FDA approved, I believe, in 2023, and she's still clean. Her lids still look good. And so there's long-term data, which we'll talk about a little bit, with XDEMVY that shows about 50 to 55% of the patients a year later were still doing well. And she was one of my extreme cases. And so how does lotilaner ophthalmic solution, or XDEMVY, work to be able to take my patient from this, and then what we originally saw when she first walked into my clinic, so this is the same patient we've walked through, to that bottom presentation. And so it functions as an antagonist to the GABA-gated chloride channels. And so what the mechanism of action is, you put it in like a drop, and it's important to the patient that it goes in like a drop. If you're talking about something that's on the lid and lash margin, the patient automatically thinks that it may be an ointment, so they want to go in like a drop. And the way that the medication works, even though it's going in like a drop, it has a lipophilic component. So that means it likes oils, sebaceous, lipids, and we find that in our oil glands. And so the medication makes its way into the lid and lash margin. And when it's there, it's being able to help reduce the collarettes, because it's getting rid of the mites basically from the inside So remember, the collarette isn't the mite itself, it's the waste product of the mite. And so that's how you're able to reduce the collarette, by cleaning it out and getting rid and eradicating that mite. The medication has to be used twice a day for 6 weeks. And so I typically schedule my patients for, when they have their evaluation, they're diagnosed, we write the prescription. I pretty much schedule everybody space out. And so sometimes they come back, they're still on the medication because there may be a little lag to receive it, or they're right on that last week that they're going to be finishing up that medication. The medication is preserved in a sorbate solution, potassium sorbate. So it's important that when the patient is using this, that they do not wear their contact lenses. They put the drop in, wait 15, 20 minutes. I usually say about 15 minutes, and then put their contact lenses back in. If they don't, this may stain the contact lens. And so it works by paralyzing the mite. And so it gets into those lid and lash margin sebaceous glands, paralyzes the mite, so therefore the mite can't eat. And then it has to be taken for the 6 weeks because there is a life cycle. So it gets the mites that are alive, it allows the time for those eggs to hatch. They become paralyzed, they can't feast, and then they eradicate the mite. So let's talk a little bit about what makes it safe, a little bit of the study. I'm not going to get too deep because this is a lid extravaganza. So I think one of my colleagues later on is going to kind of really dig deep into XDEMVY and the study. But if we're going to talk about it, when I prescribe things in my office, I always tell my patients I like to nerd out because I like to know if it's safe. I like to know if it works, and I want to get into the studies. And so there was a study that was done in SATR 1 and SATR 2, about 833 patients that were evaluated. This is still to date one of the largest studies that looked at Demodex blepharitis, and they were looking at the Demodex blepharitis with the primary endpoint in mind. And so the primary endpoint was they wanted to reduce collarettes and eradicate mites, and then a secondary endpoint was erythema cure. So when it gets rid of some of the redness on the lid and lash margin. And there was a very high responder rate to the medication, a 96% responder rate. Overall, the medication is safe. The primary endpoint was reached, which was collarette reduction. The secondary endpoint in SATR 1 was mite eradication. So that means they actually got rid of the mite. And the way that they were able to look at the mite density, I don't think a lot of us is doing this in clinic. I was lecturing, and there was actually one of our colleagues that was epilating the lash and putting it under the microscope. And so that's how they evaluated the original mite density. They would put the lash under the microscope and look up how many mites were on that lash. And then that number was gone once they were at that end of that 6-week time frame to eradicate the mite. And then the secondary endpoint was redness, improvement, and collarette reduction or cure. And so 2 successful trials, SATR 1 and SATR 2, against the vehicle, was able to meet those endpoints. And you can see the primary endpoint at day 43 or week 6, 50% of the patients against the vehicle did reach that collarette reduction or grade 0. And then just a little bit of background on the grades. Typically, all the patients that in this study started out at grade 3. And so my patient would be like a grade 3, at least 100 mites or more on the lashes. And they were able to get down to grade 0, which is like 1 or 2. And those were some stringent, some very stringent criteria that was set forth by the FDA that the medication was able to meet, the trials were able to meet. They did reach a clinical meaningful collarette reduction, 85%, and so grade 1 or 0. And so this was like, okay, so the FDA wants us to get down to like 2. What if we got down to 10 or less? So that was grade 1 or 0. And then the numbers even went up even higher against the vehicle, 85%. And they did reach the secondary endpoint of mite eradication against the vehicle at 60%. And it had a decrease in lid erythema. I've seen this myself with patients in clinic. We talk about the pathognomonic signs of the collarettes, but when you start to manage a lot of these patients, I do get patients that come in who don't necessarily have those signs of the collarettes, but they have all the other signs. They have the lid redness, the grittiness, the fluctuation in vision. And I had a patient, I walked into the room. As soon as I walked in, her lid margins were like super red and inflamed. Then I had to dig and ask her questions about the crustiness in the morning, and she helped to confirm that diagnosis of Demodex blepharitis. prescribed the medication to help with the DB, but I did also notice an improvement in her lid erythema, so the redness on the lid margin. And overall, the medication is safe. 85% of patients achieved a clinical meaningful reduction or cure by week 6. And so day 43. And so 85% of those patients, and I see those numbers in my clinic, nothing is 100%, but I do see those in my clinic where I have confidence that I can prescribe this medication and it's pretty much going to work. Those patients are going to come back and they're going to have that reduction in those collarettes. And so this once again talks about the inclusion criteria for the medication. And so Saturn 1, Saturn 2, XDEMVY is the medication, lotilaner against the vehicle. The patient's, the average age was about 66. It was female. They haven't had a collarette score of 2.8. Mite to lash, we talked about that a little bit, how they actually pull the lashes. You can see down here on the bottom that they actually looked at to see how many mites were on that lid margin. And then they did have to have some redness of the lid, so some erythema. A couple things to note that exclusion criteria. So the washout period is about 14 days, and patients could not be doing anything else. They were not doing any lid compresses. They were not doing any no warm compresses, lids cleanings. They could not have been taking any medications for blepharitis. They couldn't do anything else. And so this medication alone was able to do this. I like to bring that up so that you don't necessarily have to prescribe some of those other therapies in conjunction while you are having the patient on XDEMVY, because the medication alone can make those same clinical improvements. There are some patients that want to continue some of those things. A lot of times when you start throwing the word mite out, they're ready to scrub everything. And so it's okay if you do continue those as well, but it's good to know that when these patients was taking this medication twice a day over that time frame, that they were not doing any of those other things. And then overall, the drop was comfortable, and which is important. We are always prescribing things, and most time the patient's going to ask you, is this going to hurt? Is it going to sting? What should I expect as far as the medication? And overall, the patients that took this medication did note that it was neutral to very comfortable. The biggest adverse event, about 10% of the patients noted that there was stinging upon putting the drop in the eye, which is fairly common with a lot of medications that we use. But what's important to know is that no one dropped out of the study or discontinued because of the irritation. And once again, it was less than 10% of the patients that experienced that. And this just kind of goes over some of those ocular events here as well. And so overall, the medication is very safe, very effective, and most patients find that the medication is comfortable. And I usually ask those things when I'm prescribing medications, especially new medications when they come back, before I jump right on the slit lamp. I say, hey, were you able to get the medication? Was the process to get the medication, was that of ease? What did you experience putting it in? Did you complete the medication? So that way you want to make sure. So if you go under the slit lamp and you don't see some of those outcomes that you're expecting to see, you kind of know some of those answers by engaging with the patient before you start looking under the slit lamp. And that's me practicing that empathy-based care. And so moving on with the last few minutes, and of course, me doing dry eye, ocular surface disease, you can't forget about ocular aesthetics. And I always kind of like to integrate ocular aesthetics whenever I can, just so you can see that it's just a natural extension of any point that you're managing a patient with ocular surface disease, that beauty, cosmetics, anti-aging is just kind of part of that process of you fully managing that patient. And so poor beauty habits can exacerbate Demodex blepharitis. And so if you have heard me lecture, I think you've always heard me talk about something with these lash extensions, okay? I always do a poll of how many people are natural lash mascara or lash extensions. It's big here in Atlanta. It hit the scene before COVID. I remember talking about lashes. I even used to have a lash artist in my eye spa about 2019, 2018. 2018 is when I opened my spa and we had a lash artist. And about COVID, with us being home and wearing masks, no, lashes didn't go anywhere. People had their masks on and their lashes. They're getting their lashes done still. So there's a possible connection to lash extension and poor beauty habits with increased Demodex mites. Connection can be with the application of how you apply lash extensions because you use glue. You actually use glue. You glue, for those who are not familiar with how lash extensions work, you actually have glue that is used to glue the lash extension to the natural lash. And so that alone can cause some ocular surface issues, particularly a lot of these glues have formaldehydes in them. But with the Demodex, and the patient already had a Demodex infestation that they didn't know about that wasn't managed, then now you've created more of a feast for the Demodex mite. They may potentially feed on those glues that are there. And then here is my patient. This is my lovely patient who were coming in for our annual exam, complaining of irritation, itchiness, redness, just her eyelids were uncomfortable. And she didn't know if it was the glue because she has a new lash artist or if it was something else. And she did tell me, Dr. Davidson, I want you to look. I did opt in for the additional screening, dry eye screening, but I'm not going to stop wearing my lash extensions. And so she told me, hard stop. I'm not going to stop wearing my lash extensions. And so we evaluate, you can look that you can see some collarettes. Sometimes it's hard to differentiate the collarette from dried up glue. So you really have to look. But I said, it's okay. You know, I prefer that you discontinue wearing your lash extensions, or if you had a system in place to have more time where you have breaks, where you don't get a feel is what it's called. But if you insist on wearing your lash extensions, you know, it looks like you have Demodex blepharitis, but I do have something that I can treat and you don't have to remove your lashes. And so in Saturn 2, now Saturn 1, which is the first part of the study, the patients who wore lash extensions were excluded. But in Saturn 2, they were included. So that's good to know. So that means that the patient can take this medication, lotilaner, while they're wearing their lash extensions, and it's going to improve the Demodex without disrupting their lashes. It won't break the bonds. And so this is my patient. She took that lotilaner ophthalmic solution twice a day for 6 weeks, and she came back. Look how much better her lids and lashes look. She also noticed that she felt her lashes overall just felt healthier. And so, yep, I ran into her and she still has her lashes. And every time I see her, she's a patient, but we happen to be in the same sorority. So sometimes we'll run into each other in different events. And I always kind of look to see if I can see some buildup. And she jokingly says, Davidson, my eyes still look, they still feel good. And so definitely you can use this while the patient is wearing lash extensions. There also has been a connection with Demodex and poor makeup hygiene. So failure to apply and remove makeup. This is a big deal. You'll be surprised as many people who wear makeup who don't actually remove their makeup each night. I don't know why. Some of them, they don't know that they're supposed to. And so when you leave this additional buildup on that lid and lash margin, that patient already had a Demodex mite infestation that they didn't know about. Once again, you're just adding and increasing things for those mites to be able to increase Demodex. And so infrequent disposal of makeup. There's been some studies that have shown that Demodex can live about 5 days in mascara. And so ladies, if you're on here, you should be throwing your mascara away every 4 weeks, every month. Wink, wink. That's what we're supposed to be doing. I'm working on that. And then sharing makeup. Don't share your makeup. And so if you have Demodex, which is in your mascara already, and you share that, it can increase your risk of having Demodex blepharitis. And I always like to just throw this in here. If we have patients who come in who are wearing lash extensions, you might want to just keep this lash extension removal kit. You can treat the Demodex, but a lot of times there may be some other issues that are associated with like styes and chalazions that you may have to address that are secondary to the lash and not connection of MGD. And so takeaways, we're coming to home stretch. And so those that are on the East Coast with me, I did awesome because this is my bedtime. I literally have an elderly bedtime. So I'm doing good. I'm up and it's 9:23. So what you want to take away today is that Demodex affects about 69% of the patients, dry eye patients that have Demodex blepharitis. About 59% of patients that are coming to your office, 59 to 58% are going to have DB. You want to eradicate the root, right? And so a lot of things that we do, a lot of getting the root. You want to prescribe the medication that's going to get to the root cause of the DB. And then also you want to take away and you want to listen. So first thing, that the big thing that sticks out to me in L.I.D, listen, identify, and diagnosis, you want to listen to the patient. And that's going to help you better make sure that you get to the root cause. Then don't look down, mag up, scan, so that way you don't miss any collarettes that may be present on that lid and lash margin. And so also consider XDEMVY as one of your first line therapy options. And also lastly, this is important, devise a maintenance plan for post-treatment for your patients. Once the patient has DB, most of our things, everything have a good long-term data. Still about 55% of the patients did not have a reoccurrence in that 365-day time frame. So you want to have a process. Most of my patients that are ocular surface disease patients, I see them like I see my glaucoma patients or my AMD patients. They have a regular cadence that they're coming into my practice to be properly managed.